In this video, we'll be explaining in detail about the kinetics and kinematics of the sacral spine. So coming to the introduction, the structure of the sacral region. So as you know in the first video, the part 1 video, we already discussed about the different parts of or different regions in which I had already told you that the sacral vertebrae will be 5 in numbers and they will be in a fused manner. The 5 sacral vertebrae are fused to form the triangular or wedge-shaped structure that is called the sacrum. The base of the triangle, which is formed by the first sacral vertebrae, supports the two articular faces that will be facing posteriorly for articulation with the inferior faces of the fifth lumbar vertebrae. The apex of the triangle formed by the fifth sacral vertebrae articulates with the coccyx. So it has a base, that is, base is formed by the first sacral vertebrae and it will be articulating with the inferior faces of the fifth lumbar vertebrae or L5 bone. So the apex is formed by the fifth sacral vertebrae that will be articulating with the coccyx. So the lateral part of the sacrum or ala bears an auricular or ear-shaped surface that articulates with the ilium. So it has apex, base as well as lateral part that is known as the ala. So that is having a particular ear-shaped surface for articulation with the ilium. So the ala also bears the sacral tuberosity that is posterior to the auricular surface and articulates with the iliac tuberosity. So the ala will be also having a tuberosity that is known as sacral tuberosity that will be articulating with the iliac tuberosity. So coming to the sacroiliac articulations, the sacroiliac joints are weight-bearing compound joints consisting of an anterior synovial joint between the auricular surface of the sacrum and ilium and the posterior syndesmosis between the tuberosities of the ilium and the sacrum bone. The role of sacroiliac joints appear to be to relieve the stress on the pelvic ring imparted by the movement of the trunk and lumbar lower limbs, muscle contraction, the weight of the body, and the ground reaction forces. The main function or the role of sacroiliac joints is to reduce the stress on the pelvic ring because of the stress is mainly occurring because of the movement of the trunk and lower limbs and because of the muscular contraction and because of the weight of the body and because of the ground reaction forces. So all these factors will be leading to increase or create a stress on the pelvic ring. So this stress will be reduced by the sacroiliac joints. That will be preventing the excessive stress happening on this particular region. So the joints must allow movements to absorb the twisting forces ascending from the lower limb, yet to be stable enough to transmit the forces from the vertebral column descending to the lower limbs. So the weight of your entire spine will be carried through the sacroiliac joint and that will be transmitted towards the lower limb through the hip joints. So coming to the articular surface of the sacrum, the auricular or ear-shaped articular surface of the sacrum are located on the sides of the fused sacral vertebrae lateral to the sacral foraminae from S1 to S3. So the articular surface are multiplanar and curvy. The fetal and prepubertal surfaces are flat and smooth, while the postpubertal surfaces are marked by a central groove or surface depression that extends the length of the articulating surface. So during the fetal and prepubertal stage, the articular surface will be flat and smooth, and after attaining puberty, this articular surface will be having central groove or surface depressions. Also, the articular surface are covered with hyaline cartilage. The overall mean thickness of the sacral cartilage, which ranges from 1 to 3 mm in thickness, is greater than that of the iliac cartilage. The tuberosity is an irregular bony surface posterior to the auricular surface that articulates with the tuberosity of ilium. So this is the articular surface of the iliac bone and the articular surface of the sacral bone. So these both articular surface will be forming or articulating to form the sacroiliac joints. So articular surface of the ilium. The auricular articular surface on the ilium are covered with the hyaline cartilage. Although the hyaline of the ilia contains a denser aggregate of the collagen fibers than that of the sacrum and less than 1 millimeter thickness. So the articular cartilage thickness will be less in the ilium comparing with your sacral bone, because this articular surface will be almost 3 mm thickness in the sacrum bone, and in ilia it will be around less than 1 mm in thickness. The articular surface of ilia are multiplanar and curvy to match those of the sacrum. So both your articular surface of ilium as well as your sacrum will be multiplanar and curvy in structure. The fetal and prepubertal articular surface or articular faces of the ilia are flat and smooth, while the postpubertal surface develops a central ridge that extends the length of the articular surface and corresponds to the grooves on the sacral articular surface. So you can able to see alternate concave or convex minute articulations present in the sacroiliac joints. So there will be in prepubertal or fetal stage, it will be flat and smooth, similar to your articular faces of your sacrum, and similar to your articular faces of sacrum. In the post-pubertal stage, it will be having a central ridge. The tuberosity of ilium is a irregular bony surface posterior and superior to the auricular surface that articulates with the tuberosity of the sacrum via the sacroiliac introitious ligaments. Coming to the ligaments, that is the sacroiliac ligaments, they are anterior introitious and posterior or dorsal sacroiliac ligaments. The sacroiliac ligaments consist of the fibers, that is anterior sacroiliac ligament, introitious sacroiliac ligament, and the posterior dorsal sacroiliac ligaments. Next is the iliolumbar ligaments. The iliolumbar ligaments, which connects the fifth lumbar vertebrae to the ilium, the sacrospinous ligament and the sacrotuberous ligaments, which connects the sacrum to the ischium and are indirectly associated with the sacroiliac joints. So the ligaments that is associated with the sacroiliac articulations is here anterior introitious and posterior sacroiliac ligaments, sacrotuberous ligaments, sacrospinous ligament, as well as your iliolumbar ligaments. The sacroiliac ligaments are reinforced by fibrous expansions from the quadratus lumborum, erector spinae, gluteus maximus, gluteus minimus, piriformis, and the iliacus muscles, which contribute to the joint stability. The facial support is greatly posteriorly than anteriorly because more muscles are located posteriorly. The anterior sacroiliac ligaments are considered to be capsular ligaments because of their intimate connections to the antero-inferior margins of the joint capsules. The anterior sacroiliac ligaments covers the anterior aspects of the sacroiliac joints and joins the ilia to the sacrum. The long tailored posterior or dorsal sacroiliac ligaments have superior attachments to the posterior superior iliac spines and adjacent parts of the ilium. Inferiorly, the ligaments are attached to the lateral crest of the third and fourth sacral segments. The medial fibers are connected to the deep lamina of the posterior layer of the thoracolumbar fascia and the aponeurosis of the erector spinae. The sacrospinous ligaments connect the ischial spines to the lateral borders of the sacrum and coccyx. The sacrotuberous ligament connects the ischial tuberosities to the posterior spine at the ilia and the lateral sacrum and coccyx. So these are the ligamentous structures, that is your iliolumbar ligament as well as your anterior sacroiliac ligament, sacrospinous ligament, and the sacrotuberous ligament. All this ligament will be providing a primary restriction to the motion as well as it prevents the dislocation or any issues that is happening at the sacroiliac joints. So mainly your dysfunction will be prevented by this particular ligaments, or excessive motions will be prevented by this particular ligaments. That is your sacroiliac ligament, sacrospinous ligament, sacrotuberous ligament, and iliolumbar ligaments. So the sacrospinous ligament forms the inferior border of the greater sciatic notch. The sacrotuberous ligament forms the inferior border of the lesser sciatic notch. The introitious sacroiliac ligaments, which contributes the major bonds between the sacrum and ilia, are considered to be the most important ligaments directly associated with the sacroiliac joints. The main ligament that is associated with the sacroiliac joint is your introitious sacroiliac ligaments. So that is mainly holding this sacrum and iliac bone. So these ligaments creates the more posterior syndesmosis between the tuberosities of the sacrum and the ilia. Coming to the articulations, symphysis pubis articulations. The symphysis pubis is a cartilaginous joint located between the two ends of the pubic bones. The end of each pubic bone is covered with a layer of articular cartilage, and the joint is formed by a fibrocartilage disc that joins the hyaline cartilage covered end of the ends of the bones. The disc has a thin central cleft, which in women may extend throughout the length of the disc. The three ligaments that are associated with the joints are the superior pubic ligament, inferior pubic ligament, and the posterior ligaments. The superior ligament is a thick and dense fibrous band that attaches to the pubic crest and tubercles and helps support the superior aspect of the joint. The inferior ligaments arches from the inferior rami on one side of the joint to the inferior portion of the rami on the other side, and this reinforces the inferior aspect of the joints. The posterior ligament consists of fibrous membrane that is continuous with the periosteum of the pubic bones. The main three ligaments, that is your superior pubic ligament that will be providing superior stability, inferior ligament that will be providing or reinforcing the inferior aspect of the joint, and the posterior ligaments, so that will be continuous with the periosteum of the pubic bones. The anterior portion of this joint is reinforced by equineurotic expressions from a number of muscles that crosses the joints. So apart from these three joints, three ligaments, that is superior, inferior, and posterior ligaments, there is another one expansion, that is your anterior portion or anterior ligaments. So this will be reinforced by the aponeurotic expansion from the muscles that is crossing in the anterior aspect of the joints. So that is your so this Campanci has described the muscle expansion as forming as anterior ligament are your transversus abdominis, rectus abdominis, internal oblique abdominis, and the adductor longus. So these are the aponeurotic expansions in the anterior aspect, that is your muscles such as your transversus abdominis, rectus abdominis, internal oblique abdominis, and the adductor longus. This will be forming the anterior ligament apart from the three other ligaments, that is your superior ligament, inferior ligament, and the posterior ligaments. So all these ligaments will be providing the stability to the joints. And coming to the function of the sacral region, that is the kinematics. The kinematics of the sacral ligaments are complex and the source of considerable controversy, including the amount and type of motion available and the axis of motions. Over the years, a variety of methods to measure the motion at the sacroiliac joints have been employed. For example, 2D measurements such as those done via radiographs and inclinometers have been criticized for not capturing the three-dimensional nature of the movement at the sacroiliac joints. Three-dimensional measures utilizing Röntgen stereophotogrammetric analysis, that is RSA, have been used for measuring small amount of joint motions. Strussen and colleagues have done several studies using this technique and have examined motions at the sacroiliac joints with several movements, including moving from prone to sitting and performing the standing hip flexion test. They found that the mean amount of rotation at the sacroiliac joint to be 2.5 degrees and less than 1 degrees, and the mean amount of translation to be 0.7 mm when moving from prone to sitting and 0.3 mm when performing the standing hip flexion test. In summary, it can be concluded that the sacroiliac joints do permit motion, but only in small movements, that is extremely small amounts. Although small in quantity, this motion is important for attenuating the forces transmitted via the pelvic ring to prevent the sacral fracture. The motion that does occur at the sacroiliac joint is typically described as either symmetrical, that is agonist, or asymmetrical, that is antagonistic. Symmetrical motion is the movement of both innominate or pelvic bones together as a unit in the same direction in relation to the sacrum. Asymmetrical motion is the movement of the innominate bones in opposite directions. Because of the close kinematic chain with the pubic symphysis, any asymmetrical motion at the sacroiliac joint results in motion at the pubic symphysis as well. Symmetrical motions at the sacroiliac joints can be described by naming the motion according to the sacral movement or according to the innominate movement. Nutation is the term commonly used to refer to the movement of the sacrum, whereby the sacral promontory moves anteriorly and inferiorly, while the sacral apex moves posteriorly and superiorly. During the close chain of forward bending from a standing position. For example, the sacral will nutate on the two innominate bones immediately following flexion of the lumbosacral junctions. So during in the closed chain activity, so during your forward bending, so that is happening, that is your flexion of your lumbosacral junction, in which the two pelvic bones will be nutating. So the sacrum will nutate, or the motion happening at the sacrum will be nutation over the two pelvic bones. So next is about the posterior pelvic tilt. It is a term commonly used to refer to the symmetrical movement of innominate bones whereby the ASIS and pubic symphysis moves superiorly. So this is the sacral nutation. So in this sacral nutation, the sacral promontory will be moving anteriorly and inferiorly, and the sacral apex will be moving posteriorly and superiorly. The sacral promontory will be moving anteriorly and inferiorly, and the sacral apex will be moving posteriorly and superiorly. So this is what happening during the nutation or forward flexion of the lumbar spine or your lumbopelvic rhythm. So apart from this, there will be posterior tilt or posterior pelvic tilt occurring in the pelvic bone. So this is what happening during the forward flexion. So both your sacral nutation as well as posterior pelvic tilt will be happening during the forward bending. So counter nutation refers to the opposite movement in which the sacral promontory moves posteriorly and superiorly, while the sacral apex moves anteriorly. Anterior pelvic tilt is the term used to refer to the symmetrical movement of the innominate bones, whereby the ASIS and the pubic symphysis moves inferiorly. During the open chain task of bilateral hip extension in prone, for example, anterior pelvic tilt of the two innominate bones will occur on the sacrum immediately following maximum hip extension. So this is what happening during the bilateral or during the hip extension. During hip extension, so there will be anterior pelvic tilt happening during this hip extension, as well as sacral counter nutation occurring at the sacrum. So during counter nutation, the sacral promontory will be moving posteriorly and superiorly, and the sacral apex will be moving anteriorly. The sacral promontory will be moving posteriorly and superiorly, and the coccyx will be moving, the sacral apex will be moving anteriorly. So this is what happening during the hip extension. Asymmetrical motion at the sacroiliac joint is described as pelvic torsion of the innominates on the sacrum. Asymmetrical motions occurs during asymmetrical tasks such as ambulation or your walking or gait, in which one hip is in a flexed position while the opposite hip is in an extended position. The innominate or the pelvic bone on the side of hip flexion will be torsion in the posterior direction, while the innominate or pelvic bone on the side of hip extension will be torsion in the anterior direction. Pelvic torsions are always accompanied by motions at the pubic symphysis. So this is the summary of your hip flexion as well as your hip extension. During hip flexion, there will be sacral nutation and posterior pelvic tilt, and during hip extension, there will be sacral counter nutation as well as your anterior pelvic tilt will be happening. So coming to the kinetics, the stability of the sacroiliac joints is extremely important because these joints must support a large portion of the body weight. In normal erect posture, the weight of the head, arm, and trunk is transmitted through the fifth lumbar vertebrae and the lumbosacral disc to the first sacral segments. The force of the body weight creates a nutation torque on the sacrum. Concomitantly, the ground reaction force creates a posterior tilt on the innominates. The counter torques of the nutation of the sacrum and the posterior pelvic tilt of the innominates are supported by the ligamentous tension and fibrous expansion from the adjacent muscles. which reinforce the joint capsules and blend with the ligaments. The iliolumbar ligaments have a significant role in stabilizing the sacroiliac joint as well as the lumbosacral junction. The ventral band of the iliolumbar ligament is of particular importance in restricting the sagittal plane sacroiliac joint mobility. Also, tension developed in the sacrotuberous, sacrospinous, and anterior sacroiliac ligaments counteracts the nutation torques of the sacrum. Although the sacrotuberous and sacrospinous ligament have not been found to play a major role in the pelvic stability. However, the sacrotuberous and introsseous ligaments compresses the sacroiliac joints during nutations. The long posterior or dorsal sacroiliac ligament is under tension in the counter nutation and relaxed in nutations. The long or the dorsal sacroiliac ligament will be relaxed in nutation movement and it will be in under tension during the counter nutation movement. The introsseous sacroiliac ligaments binds the ilia to the sacrum. The complementary ridges and depressions that develop in the cartilage of the sacrum and iliac surfaces also contribute to the stability of the joints. Vertical load bearing is facilitated by the development of these ridges and depressions, but motion is limited by them. Shearing forces are created at the sacroiliac joints and symphysis pubis during the single leg support activities as a result of lateral pelvic tilting. Under normal circumstances, the joints are capable of resisting the shearing forces and no appreciable motion occurs. If, however, the pubic symphysis is dislocated, the pelvic becomes unstable during gait with an increased stress on the sacroiliac and hip joints as well as the vertebral column. So if there is a dislocation happening in the pubic symphysis joints, this the pelvic region will be becoming unstable during walking, and in order to compensate, there will be an increased stress over this other joints such as your sacroiliac, hip joints as well as your intervertebral joints. So by this we are concluding about the kinetics and kinematics of the sacrum bone. So thank you for watching this video. Please do subscribe and share this video to your physio friends as well as your physio fraternity. Thank you.